Welcome to the discussion of the Uworld question ID 4053. The personal history of this patient: he's 65 years old, he is male. The past medical history include hypertension, diabetes, and myocardial infarction. All these four things, hypertension, diabetes, myocardial infarction, and 65 years old, are risk factors somehow for the congestive heart failure. How is that? Hypertension is the most common cause of congestive heart failure. Myocardial infarction is a cause as well, because dead muscle cannot pump properly, it causes congestive heart failure. Diabetes and increased age are risk factors for myocardial infarction. This is how they play a role in congestive heart failure development. So, myocardial infarction itself can cause congestive heart failure later on. The present complaint is dyspnea, started 2 months ago, and it's getting worse. It's progressively worse. Vitals include normal temperature, normal body temperature. It typically excludes infection. The pulse is 65 and respiration is 18 per minute, and I'm expecting increased pulse and increased respiration. Since he's short of breath, I'm expecting more pulse and more respiration, but I don't know why it's not happening in this case. The blood pressure is increased, 156/96. It's common heart failure due to sympathetic stimulation. That's why I'm expecting increased pulse and increased respiration. If there is hypotension, it means this heart failure is severe and there are worse outcomes for this heart failure. I don't know why he didn't perform oximeter test. He didn't see the saturation, auto saturation, by using the pulse oximeter. I don't know why. And this is really crucial and critical in managing any case of shortness of breath. You have to know whether or not he has hypoxemia. It's not available. He didn't give any information about it, and this is weird. By examination, we do inspection, palpation, percussion, auscultation. By inspection, we saw edema. Analyzing this edema, it's bilateral. It's not unilateral. It's bilateral. Means it's more systemic cause, most probably a systemic cause. It's pitting. Pitting means something related to the cardiovascular system, related to the venous system or the arterial system, instead of non-pitting edema, which is caused by lymphatic obstruction or myxedema. The grade 2+ means it's the indentation made by pressing over the edema is 4 millimeters. 1+ means 2 millimeters. 2+ means 4 millimeters. 3+ means 6 millimeters. We multiply by 2 and so on. 4 is 8 millimeters. That's it. Up to the knees means there is an extensive edema. It's not just to the shin or to just foot edema. Positive hepatojugular reflux, it's done after recognizing there is edema. It differentiates the cause of the edema, whether it's from liver disease or is it from heart disease. We compress the abdomen for 13 seconds, for 30 seconds, half a minute. And then we see, is there a jugular venous distension or not? After compressing the abdomen, the upper abdomen, the gastric region, for 30 seconds, if there is jugular venous distension, it means the edema is caused by cardiac cause. If there is no jugular venous distension, it means the edema is caused by hepatic cause. By palpation, the second part of the examination is palpation. We palpated the chest. The maximal impulse is displaced downward and to the left. There is a lateral displacement of the apex of the heart. Maximal impulse indicates the apex of the heart, and it's displaced to the left laterally. This means there is an enlarged heart, hypertrophic heart due to hypertension. Something not done or not mentioned is tactile fremitus. You put your hands on different chest regions and ask the patient to say 99. And you expect a decreased tactile fremitus in cases of pleural effusion. And in this case, it's a case of pleural effusion. I'm expecting, if he did the palpation this way, the tactile fremitus, I'm expecting a decreased tactile fremitus. By percussion, it's not done as well, but I'm expecting a dullness at the region of the affected pleural effusion. Right-sided dullness in the lower part. Okay, that's what I'm expecting. It's not done, it's not mentioned, and it's something to note. By auscultation, there is a systolic murmur at the apex. It's most probably due to mitral regurgitation, due to enlarged dilated left ventricle. It's dilated, the mitral valve is insufficient anymore, so there is some sort of mitral regurgitation. There is a decreased breath sounds at the right base. This is due to pleural effusion. The investigation requested is chest X-ray. And by chest X-ray, the physician diagnosed this as pleural effusion. How did he do that? By the costophrenic angle obliteration, this whitening and the obliteration of the angle. That's how he diagnosed this as pleural effusion. In the serum, protein is 6.5, the LDH is 320. I don't know why is it done. Okay, I don't know why is it done. It's done to compare between the pleural fluid and the serum fluid. The protein inside it and the LDH inside both of them, and compare them. But the thing is, it's not routinely required. So it's just required for this case. I'm wondering if the orders of the information given in the question is right. Like, he gave me this information before telling me that the physician asked for thoracocentesis. So the first thing, you would ask for thoracocentesis and ask for serum protein and LDH after you request this. Okay, now I'm going to do thoracocentesis. I need to know the serum fluid and to compare the serum fluid and the pleural fluid. That's when I do the protein and LDH. It's not routinely done. Okay, that's the thing. Anyways, management, the physician decided to perform diagnostic thoracocentesis. But in cases of pleural effusion with evident congestive heart failure, we should try diuretics. Even if this thoracocentesis is a minimally invasive procedure, we wouldn't do it in this case. But I think most probably this is done for the purpose of the question, since diuresis changes fluid criteria into exudative. The congestive heart failure pleural effusion is transudative. But if we give diuretics, this will relieve this pleural effusion. The fluid in the pleura will decrease, so increasing all the protein and LDH levels, the concentrations inside the pleural fluid. This will change the fluid from a transudative fluid into an exudative fluid criteria. That's why he did the thoracocentesis before the diuresis step. But in real clinical practice, we directly give diuresis to congestive heart failure patients who develops pleural effusion. This is called light criteria. Okay, it's the differentiation between exudative and transudative pleural effusion. So these are the criteria. The pleural fluid protein is more than 0.5, half of the serum protein in the exudative. Exudative means infection, and these are the criteria for it. The pleural fluid LDH is more than 0.6 of the serum LDH, and the pleural fluid LDH is more than the 2/3 of the upper limit of normal pH LDH. So the upper limit normal LDH, I don't know why they keep it this way. The upper limit of normal LDH is 200. If we want 2/3 of 200, it's 133. They can just say 133. I'm not sure why is it given this way in the light criteria. I'm really not sure. And I don't know if it's different for males and females or different age groups. I'm not sure about this. Anyways, the pleural fluid of the exudate is 7.3 to 7.45. Above that, it's going to be transudative or normal. Something to note that in the questions, so the right answer was the pleural fluid pH higher than 7.45. It was something higher than that. So this is what I'm expecting to see in this pleural effusion due to congestive heart failure. One of the answers included high amylase in pleura. This would be typically seen in two cases, esophageal rupture or pancreatitis. Okay, so what causes esophageal rupture? Some cause like iatrogenic, if you used endoscope and you perforated the esophagus, swallowing of a foreign object that perforated the esophagus, Boerhaave syndrome, which is extensive, strong vomiting, lead to rupture of the esophagus. This can lead to high amylase in the pleural fluid. What is parapneumonic effusion? This is something else you have to note. With pneumonia, there might be pleural effusion. It happens only in 40% of cases of pneumonia. And this effusion is sterile. It's fine. It's just sterile. But if bacteria came inside it, if the bacteria went inside this effusion, we call it complicated pleural effusion. Complicated pleural effusion means bacteria. Like complicated parapneumonic effusion means there is bacteria in the effusion. So we give drainage as a must. We should do drainage. We should drain this effusion along the antibiotics. We are going to give antibiotics either ways because this is caused by pneumonia. We're going to give antibiotics. If it's uncomplicated, it's fine. If it's complicated, the bacteria came inside the pleural effusion, we should drain this fluid. We have no other way. We have to drain along with the antibiotic. Antibiotics alone won't work. How to know this is a complicated? How to know the bacteria is inside? By this criteria. The pH of this fluid we take is 7.2, below 7.2. The glucose is below 60. The white blood cells are more than 50,000. That's what defines complicated pleural effusion. Complicated parapneumonic pleural effusion. One of the answers was something related to the glucose level. So this is just used in the parapneumonic effusion. Another thing to note is, commonly, the congestive heart failure happens bilaterally in 61% of the cases. Sometimes it's on the right side, like in this case. It happens 27% of the times. And it happened to be in this case. It happens only on the right side. It happens on the left side rarely. It's in 12% of the cases. And that concludes our question. If you have any question, do not hesitate to ask in the comment section. Thank you and good luck.